We will speak about brief introduction about orthodontics and know the history of it. Orthodontics aims for three main things: maintaining the functional efficiency, which is the mastication and the phonation, then the structural balance between the jaw, tooth, and the soft tissue surrounding, and maintaining the aesthetic harmony by aligning the tooth inside the jaw to increase the aesthetic aspect for the patient. And it is the main cause that patients seek for orthodontic procedure. So this can be achieved by several branches, which is the preventive orthodontics, or the interceptive, and the corrective. As for the preventive orthodontics, it starts when there is no any malocclusion that has appeared, but we must take precaution. For example, if deciduous dentition started having caries, we should do restoration to maintain the arch length, and we must keep monitoring the eruption timetable of the tooth. Also, we must take note if any oral habits that develop that may cause any malocclusion in the future, and we remove any retained deciduous teeth and any extra teeth in this stage. But when some malocclusion starts to happen, we can do what is called an interceptive orthodontics to prevent any advancement of the malocclusion. And these procedures can be like serial extraction of the tooth, correcting anterior crossbite, and controlling abnormal oral habits, also removing any extra tooth. So the corrective orthodontics happens using two types of appliances, which are the removal orthodontics appliances and the fixed orthodontic appliances. The functional and the orthopedic appliances are usually used in the phase of development and growth. The movement of the tooth happens using the fixed and removable appliances, but the difference is that the removable do only tipping movement on the crown of the tooth and provide minimum movement of the and positioning. It can be used as a passive appliance to maintain the teeth in their corrected position, but the fixed appliances can do rotation and bodily movement and torque movement of the whole tooth, which means that it's the root and the crown. Functional appliances utilize the forces of the circumoral musculature for their action, and they hold the mandible away from the normal resting position to affect the growth modification of the mandible. But the orthopedic appliances, they apply high forces that are external, and they do to act on the skeletal growth and do changes on the skeletal aspect to correct any malocclusion and growth by doing growth modification. Choosing the right time, age, and the appropriate appliance is a crucial step in getting good results of treatment. The best time for doing the treatment is the late mixed dentition, or the early permanent dentition stage, but for the surgical treatment, it is usually carried in the late teens and the early adulthood. Also, we must take into account the etiological factors that made this malocclusion, like for example heredity or any environmental factors. For example, if a child inherited a mother's small jaw and father's large teeth, they may have to develop crowding in the arch, or they may develop any environmental oral habits like thumb or digit sucking, lip biting, and mouth breathing. And what we have said, we can give a definition for malocclusion, that is any irregularities in occlusion beyond the accepted range of normal. What does that mean? It means that not all malocclusions need treatment. Treatment in mildly unesthetic and non-determined to the health of the teeth and their supporting structure may not be needed and not justified. So, orthodontics is a branch of dentistry that is concerned with the growth of the face and the development of the occlusion. And what to do? We do three things: we prevent, and we intercept, and we correct. It is this orthodontics is a Greek word that is divided into two syllables: the orthos, which means right or correct, the odontos, which means tooth. The British Society of Orthodontics gave a definition that it is the study of growth and development of jaws and face and their influence on the position of the tooth, and study any action, whether it is internal or external, that influences this development. Some procedures that are considered minor in orthodontics is using the mouth guards, that they are used for when there is applied pressure on the teeth when performing some certain sports. So we do a guard that will protect the teeth, or if the patient has bruxism and clenches on the teeth, we use night guards, which is the same thing, but the patient wear it at night. Cleft lip and cleft palate are anomalies that may develop from syndromes, and they need many branches of science to manipulate this kind of problem, because the patient need to develop a way of speaking well, and deglutition, mastication, and speech. Besides that, there need an orthodontic treatment to maintain the width of the jaw. In some cases, we may need a surgery. As for history of orthodontics, it is considered the oldest specialty in dentistry, starting from the 19th century, that it was recognized as an independent specialty. Edward Angel is considered the father of modern orthodontics. He made the famous malocclusion classification, and this is Edward Angel. He organized the first orthodontic society and called it the Society of Orthodontists. In 1935, it was named the American Association of Orthodontics, and they have a journal that is concerned with everything that is ortho. He also developed what is considered the base of the fixed appliances, and it is called the edgewise appliance. It has here an edgewise brackets, can support three-dimensional movement, mesial distal movement, buccal palatal movement, and torque movement of the root, which is the movement of the root. In the beginning of this specialty, France was the leader in dentistry throughout the world in the 18th century, and we have seen that the development of the removable functional appliances was mainly in Europe, but the Americans preferred the fixed orthodontics appliances, the myofunctional appliances, which exert a force on the mandible to change its position. Has three main types, which is the activator, the twin block, and the Franklin and the bionator. Let's talk a brief history of each of them. For the activator, it was called the monoblock. Viggo Anderson used it on his daughter when she was on vacation for 3 months, and observed so much sagittal correction and improvement in the facial profile. So it is used for position of the mandible forward in patients with glossopotosis and severe mandibular retrognathism. By positioning the mandible forward, it reduces the risk of airway obstruction. So it acts on the growth of the mandible, whether it is retract or protrude it. Hey, this is Viggo Anderson, and there's many modifications on the activator or the monoblock. For the Frankel appliance, it is developed in Germany in 1966. It is tissue-borne, mostly supported in the vestibular rather than supported by the teeth, and it has 5 types that can be used to manage Angel's class 1, class 2, and class 3 malocclusions. The bionator has also been developed in Germany in the 1950s. For the twin block, it is composed of maxillary and mandibular retainers that fit tightly against the teeth and adjacent supporting structures. It produces an increase in the mandibular length and the incisor proclination and variations in the lower anterior facial height. It also can be trimmed to facilitate the eruption of lower posterior teeth with deep bite, and it can be used to modify the curve of SPI. If you want to speak a bit about the history of the cephalometric image, it is the cephalometric radiography was introduced in the 1930s, and it was first we got it from the anthropology science, because first the skeletons were used to study its shape and dimension, so it was not entered in dentistry mainly or in the first place. There was at first taking the measurements of the skull was inaccurate because the head was covered with soft tissues and marks. But when the radiography has emerged in the 1895, there was suggested that we take cephalometric images of the skull, but it's entering as a tool for diagnosing was not until the 1930 by someone in the USA that was called the Broadent, and in Germany Hofrath. So they suggested using a new X-ray technique in application of orthodontia. Until 1948, where William Downes, this man, he developed a number of cephalometric analyses and to compare patient to his or her peers by using population standards. But what we use today is the analysis of Richard Riddle. This is Richard Riddle, who introduced one of the most widely accepted diagnostic cephalometric measurement in the use. So to sum things up, orthodontic as an idea was recognized way before in history, that we see here in the Roman era. Celsus, the author of the 1st century, he described the finger pressure to move the teeth in his work. He said, when in a child a permanent tooth appears before the fall of milk tooth, it is necessary to dissect the gum all around the latter and extract it. The other tooth must then be pushed with the finger day by day towards the place that was occupied by the one extracted, and this is to be continued until it reaches its proper position. So it was mentioned way before in centuries, the concept of tooth movement, but it was given its name and proper classification and speciality in the 1899 by Edward Angel, and as we said that it was in the 18th century, it was mainly based in France, that was leader in this field, in dentistry in general. Then we have seen how the cephalometric image has developed and went from the cranial and the anthropology field to the dentistry field. We have seen the contribution of doing some analysis to study these X-ray images. Then we have seen the development of the myofunctional appliances that were developed in Scotland, Germany, and in the US, with all its modifications that we will talk about more in deep when we reach to this lectures. And that's it for now. Let's answer some Q&As to make sure that all of the information is fully understood. Orthodontics is the branch of dentistry concerned with prevention, interception, and correction of malocclusion. So it is B. Odontos, we said it is teeth or tooth, and it is a Greek word. The orthodontic treatment brings about a change in dentition, the facial, the dentofacial structure, all of the above. What is the aim, objective of the orthodontic treatment? The pyramid, if you remember, the functional, the structural, and the aesthetic. So it is all of the above. What is the most common reason for seeking orthodontic care? Is the aesthetic. Where is it? The aesthetic harmony. B. Who advocated the use of finger pressure? We said it was the Celsus. Who made the Edward Angel brought forward the classification of the malocclusion? So he is the founder of the modern dentistry. No, he is the father of orthodontics, but the founder of modern dentistry is Pierre Fauchard. We did not speak about him. Okay, move on. Pierre was a French dentist. The monoblock, its main function is to protrude the mandible forward. So it is used in class 2 skeletal malocclusion. Edward Andrew was basically a prosthodontics. Malocclusion is the abnormal deviation of normal occlusion. At what age can orthodontic treatment begin? It can begin in 60 years, which is the start of permanent dentition, which is the first phase of the mixed dentition, we can say. But we said that the optimum time is the late dentition and the first primary. That's it for today. See you soon. Salam.